All right, good morning, everybody. Welcome to Department of Medicine Grand Rounds. Today, I'm pleased to introduce Dr. Adriana Palade, UofL Professor of Neurology, today's speaker. Dr. Palade joined our faculty at UofL in 2015 and has been an absolutely vital force in the Department of Neurology. She serves as Neurology Residency Program Director, Chief of the Division of Epilepsy, Director of Epilepsy Monitoring, Director of the Epilepsy Surgery Program, and for the past 2 years has completed a stint as Interim Department Chair. I think I got all the titles in there, the most important ones. In addition, her CV boasts publications, invited speakerships, and clinical trials, all in the field of epilepsy, in addition to several teaching awards and involvement with national associations. Today, we're pleased and grateful to have her here with us in the Department of Medicine to discuss the medico-legal aspects of epilepsy. So please join me in welcoming Dr. Palade.
Thank you. Thank you for inviting me here. I'm discussing a topic that I'm hoping is going to bring something new to everyone watching. Some things that we try to incorporate in the resident training. I feel sometimes we don't do enough of it. So I'm just going to start. These are all real patients that I've seen either here or my prior workplace at different university. So real studies, real cases. So first patient, it's a 27-year-old, actually neurosurgery resident. We're in the process of buying new machines for the lab. Before we swap the machines to make sure the integration is smooth, we try to find volunteers to record the studies for several hours, make sure the quality is good, and then over weekends we try to graduate to the new machines. So we're testing a new latest EEG machine. He walked in the lab. We said, "Do you want a nap for a few hours?" And he said, "I'm always looking for a nap," which is not unusual for a busy resident. So the purpose was to get 1 to 2 hours of resting EEG where he would potentially fall asleep. He did fell asleep, and 9:30 the pager went off, and he got up. We took the leads off, and he went to his work. I was in clinic. I came around 6 o'clock to just look at the recording, be able to screen for some of these. We had 2.5 hours of EEG recorded, both wakefulness and sleep. And this is the EEG recording at the time. For those of you that have never seen an EEG, the labels on the side are either even or odd numbers. Odd are left, even are right. And the FP2, for example, is the frontal polar electrode being with the 2, it's going to be on the right. F is frontal, C is central, right on top of the head, P is parietal, on the back of the head, O is occipital, and the T's are temporal lobes. Some of them are right above the ear, some in the anterior temporal right where the kind of glasses sit. So they're linked one to another. Because of that, it's called double banana montage. They look like 2 bananas on the head. So this is an EEG of about 25 seconds. The first portion, which is right here, the first few seconds, really about 5-6 seconds, represents sleep. Then you see this big junk, really, followed by another 1 to 2 seconds of sleep. So essentially on the video portion of the study, he got up, had lip smacking, he was wide awake, had dystonic posturing, drooled, turned the head, and then went back to sleep. So based on the EEG that has clear changes seen in the frontal head regions here and here, at least about 3 seconds of clear changes and clear rhythmicity here at the end. And the duration, which is 10 seconds. So anything over 10 seconds is considered a seizure. So he has essentially a frontal lobe seizure. He had 3 of these recordings happen in the first, I would say, 45 minutes of sleep, followed by another 35 minutes of normal sleep. So at 6 p.m., don't know where he is. I have somebody that probably operates and had 3 seizures recorded, no prior history, nothing that we knew. senior resident looking actually for a job. This is February, right before he signed off for a job. So the question is, what do we do with this information? There are several questions that come out of this. So he volunteered. Is this medical information valid? So the answer is probably valid. I mean, it's clear seizure. Does HIPAA apply in this case? There are lawyers that would argue that HIPAA only applies when the patient seeks medical care. He did not seek medical care, he volunteered. So what do we do with HIPAA in this case? Do I have to report the finding, and to who? I mean, I was the only one in the room. There's no technician there. What do I do with this? I mean, it can ruin somebody's life, but it can also ruin a bunch of other people's lives. And what are implications for employment and for driving? So those are all kind of things that went through my mind. I've actually been part of the American Board of Psychiatry and Neurology, the Committee for Questions Writing for Neurophysiology and Sleep. And two of the most difficult assignments really are the two questions of ethics that we have to write. It's just so hard to have EEG and EMG and write ethical questions, something that doesn't repeat. But this is one of my questions that I wrote. And everybody thought it was a wonderful question, but it ended up being tossed. We said, this is a terrible question. Nobody can answer. All 12 of us have different arguments and we can make a point. So it's tossed, although it's a valid question. So I wanted to reach out and discuss some of the medical ethics principles that a lot of you probably already know. Beneficence is the core principle in medical ethics that promotes and protects patients' well-being and interests. Non-maleficence is the active avoidance of any act that would cause harm, including neglect. It's also known as the primum non nocere in the Hippocratic Oath. Autonomy, all patients having intrinsic and unconditional worth, they should have the power to make rational decisions as well as moral decisions, and should be allowed to exercise their own capacity for self-determination, which is very powerful and very much needed. If we can do anything in somebody's terminal, we should be able to preserve their autonomy. Veracity is the practice of being truthful to patients, and of course, justice, fair, equitable treatment of all patients. So with this in mind, let's discuss the case. So the EEG findings are clearly delineated. There has been additional medical information obtained based on discussion with him. Never had a history of seizures, never had a car wreck, never had any unexplained episodes of loss of awareness, loss of consciousness, car wrecks. Nobody has ever had complaints within the department or program about his. The employer has the right to request medical examination related to disability claims or at any time when impairment at work is witnessed. It's not unusual and it's done quite often, but it's not something that he had because he was functioning. He was of the 2 residents in a year, he was the one that was selected by peers and faculty as chief resident. We've talked to him about what to do, and he decided that it's best to communicate to this program director. We advise him to seek an independent medical opinion, and he did. I hear that he's practicing still in the state of Texas. I cannot comment on whether or not he's on any medications, how he's doing, but it was kind of life-changing for him, intensely stressful, because it had to be reported and it has clear consequences on everything. So when I called to talk to him, he was operating. Somebody picked up the phone and said, I'm answering for Dr. James. And I said I would need to talk to him. And he said, it's okay, you can speak, you're a speaker. I said, no, I really can't. So it was shocking. He went through all the motions. Within minutes of finding this out, really didn't know what to do with this. So what he has is sleep-related hypermotor epilepsy. It's an autosomal dominant nocturnal frontal lobe epilepsy. The good thing about it is that just almost 99% of the seizures occur while asleep. So granted that he doesn't fall asleep while operating or driving, he probably doesn't have major restrictions on driving and probably not even practicing. He tends to have an onset before the age of 20. He was 29 at the time, so just a little older. The seizures are brief hypermotor seizures. They usually have bicycling movements of the legs, extend their legs, they fidget in the bed. The seizures can look like simple arousal, just awakening when patients turn in bed, may have some odd posturing of the head and maybe drooling. They may feel them as their nightmares or night terrors. The movements are quite variable and many times they're dismissed. Even if patients come in emergency room and have something witnessed, they're labeled as night terrors. These are related to the nicotinic receptor subunit genes and the potassium channel genes. So it's a kind of mixed genetic underlay. And it's a lifelong condition. It is not progressive. Patients never really grow out of it. Seizures tend to become milder and less frequent with age. And in terms of testing, a lot of patients are intellectually normal. They're doctors, they're lawyers, they're nurses, they're teachers. So the relationship with sleep, I think, makes it some. For one, this may not be a just really bad one to have, just because it has very little implication with driving and practicing. However, given the fact that these seizures tend to be major, I think it's always important to remember SUDEP. It's a real thing, sudden unexpected death in epilepsy. It happens I almost always tell patients, you are the perfect fit, not that I want to happen, but they're males, muscular, before 40. And those are the ones that are likely to die from the SUDEP. It has to do with the cardiorespiratory arrest and incomplete recovery after a seizure, where patients, I tell always the families and patients' families, make sure you wake them up. I don't need them to be oriented only to the place that is, but I need them to be able to take a deep breath, and then you can let them go to sleep. Don't just let them sleep. Wake them up and then let them go to sleep, because that's how you delay or avoid SUDEP. This is another patient, the typical 4 o'clock new patient in the clinic. It's a Monday, snowy day. Almost everybody's done because the patients are gone. So it's just me and a nurse in the room. So I walk in. This is a 72-year-old lawyer, lived about 30 miles away. This was the second evaluation for syncope. He's an impressive guy, well-spoken, well-dressed, holds his coat, he's engraved his initials, his socks, and his, everything. You can tell he's well off. He has the car keys and he's sleeping, in his hands, and it's a Mercedes. He has a history of hypertension and prostate hypertrophy. He doesn't want to share much, but he said, I came one day to work. I always open the office. I'm 73 very soon, and I've been in that practice for 40 years. I have 12 people working for me, lawyers too. And she found me fallen out of the chair and confused. He was taken to a local hospital, seen by a neurologist, believed to be a seizure. He refuted the diagnosis. At the time of the event, he had bladder incontinence. And he has brief confusion, a little bit of retrograde amnesia. He remembers coming in, putting the coffee, but doesn't remember anything until he gets in the hospital. So he's got about 15 to 20 minutes time lapse there. That's significant, and it's not usually something we see with syncope. He had 1 hour EEG done in ER, was normal. He said, see, it was a seizure. Started examining him. He sat back on the chair, and then as I was typing, we had Epic as well. He has this brief episode of psychomotor arrest. He starts humming. He turns the head a little bit toward the left. He's drooling. He drops the coat, drops the card. I give him 3 words to see if he remembers anything. Then he starts clearing his voice, and he can't answer. And can't remember, can't repeat. It wasn't very long, it was about 20, 25 seconds. Speech resumed immediately. I said, do you remember the words I gave you? And he said, what? And I said, do you remember the words I gave you? I gave you 3 words. Do you remember that? He said, no. And I said, you don't remember? He said, no, I don't understand your accent. I said, okay. So I said, I have reasons to believe that this was probably a brief seizure. It's probably what happened in your office. And he said, nothing happened here. And I said, well, it did. And I said, it's, we're in a situation where we have to decide what do we want to do. If you would ask me, I would prefer that you come and stay in a hospital overnight. We do some EEG testing and just to make sure you don't have another event. And he said, absolutely not. And I said, okay, if you don't want to come in a hospital, at least we'll go to the emergency room, we'll have a brief evaluation. And he said, no. He said, I'm going to go home. And I said, well, you can't go home. You're obviously driving. And I said, do I have your permission to talk to your wife? To maybe she can come and pick you up. And he said, no, nobody needs to know about this. So I'm in a situation where I need to do whatever is best for everyone, including for him. And he's refusing. I was debating, is he able to, is he decisional at this point? The state of West Virginia to declare him non-decisional, he needed another physician. There was nobody around. And actually he insisted, he got up and he literally left within minutes. And it was disturbing. The nurse left, went home, I finished my note and everything. And so the question is, what do you do in these instances? So depending on the state, there are state mandated driving restrictions. The AMA's Code of Medical Ethics says that the physician has a responsibility to recognize impairment in patients' ability to drive that can pose a strong threat to the public safety. So he was right there. I actually asked one of my colleagues that was older. Next day, I said, this is what happened. What should I do? I feel like I need to report him to DMV. He's clearly not listening and he's denying what he's having. And his answer to me said, do you typically report your patients to DMV? I said, no, I documented in a chart. West Virginia went from 12 months restriction in driving to 6. So it was a big gain for us, after we advocated. But 6 months is still a long period of time. And he said, no, he can make, and when he left, the day before, he said, you really can't do very much. He said, I can ruin you. There was a clear threat. So Jack said, unless you report everybody, you can't just single him out and report him. You have to document the fact that you have discussed with him, you believe he understood, and he made the decision to drive, which is what I did. There is a rulings in the Tarasov case, which states that the physicians are required to report a clear and significant danger to identified party. However, if he would be on the road, the pedestrians or the other drivers will be considered non-identifiable parties. So there is not a clear danger. I mean, there's a clear danger, but there's nothing identifiable. And because of this, any court will be unlikely to find a physician civilly liable if a third party is injured. It's not ideal, but that's the law, and I went through some of the cases. Before I bring this up, so I don't have much of a follow-up for him, as far as I know. We had a similar case that I was involved actually in a medical lawsuit. I was just doing a deposition, painful, long deposition, but it was somebody seen in the residence clinic. They came with repeated non-compliance. But one day he came in our emergency room, different university. They came in emergency room with nausea, vomiting, had to wait a couple of hours before he was taken back, but had 2 witness seizures in the waiting area, prompting him to be brought back. Low dilating level, loaded orally, which takes time to kick in, level of 4 instead of just being therapeutic 10 to 20. And discharged about 8 hours later without having a dilating level checked, and he got in the car, drove, ran the car off the bridge, and died. So family was suing because we did not impose on him the driving restriction. There was a lawsuit about you should have never let him go. You should have kept him there. And I found out that the hospital door is the out of the door. You can't do anything, and he left and went to the parking. So we don't have to enforce, we just have to advise. We have to document what we discuss and we have to advise, but we don't have to enforce, luckily or unluckily. So this is another patient. I have to show the video. Can you show me how to? let me go through this slide first. So he's a 30-year-old male brought in from police custody, seen by a chair at the time. He was arrested for strangling his boss and has a prior history of suffocating his girlfriend, resulting in domestic abuse charges and a restraining order. He has no past medical history and no medications at the time he was seen in a neurology clinic. We had a recorded phone video clip from the girlfriend that showed exactly this picture. He has no recollection of events. He said, I'm not a violent, guy. It happens very rarely. Sometimes I just do things I'm not aware of. He was working in early education and daycare and had prior clearance for employment. So temporal lobe epilepsy based on EEG and based on description consists of psychomotor arrest, oral automatisms where patients have movement that are kind of lip smacking, sometimes like fish-like described movements, manual automatisms, which are non-personal movements of the hand ipsilateral to the seizure focus. So the seizure comes from the right, they'll have movements. And you saw his hand, he was grabbing with the right hand and throwing. So it was a right temporal lobe seizure based on EEG, but also everything that he did was right-sided. Occasionally they have dystonic posturing, that's on the left. It's weird, sometimes it's thumb sticking out or hand, non-purposeful, maintained posture. He had recurrent episodes with so he was labeled by psychiatrists as episodic dyscontrol and intermittent explosive disorder. It is known in epilepsy, the amygdala involvement plays a crucial role in this mediation of aggressive behavior. And temporal lobe seizures don't come just from the hippocampus. The amygdala hippocampus are very much linked together. The criminologist, a classical criminologist, proposed the Lombroso essentially proposed the epileptic criminals definition, which means inherently violent, practice of exhibitionism, psychosis, hypersexuality, and absent. I had a different patient, different gender in the 60s. The reason for showing up for epilepsy surgery and trying to be evaluated was the fact that she had recurrence of, she would unclothe entirely, and she was evacuated from so many homes. She could never find a home. She couldn't find the landlord. She was aggressive. She was loud, and she would be running up and down the stairs in a hallway and in the streets naked. And so essentially became homelessness because of her disabling epilepsy, and proceeded to have, it was right temporal lobe epilepsy as well. So became seizure free and found a home after hospital was a psychiatric hospital, about 300 beds, where we would practice, me and the other fellow alternating on Thursdays. So one of the things we always looked for were EEGs of patients that came in certain aggression or behavior that they believed to be seizures. So there were 2 additional cases of patients that have truly epileptic behaviors, temporal lobe seizures, that got them admitted to psychiatric units. So those they seem rare, but if looked, hard enough, especially in the psychiatric unit, are not that rare. So the insanity court defense considerations. The diagnosis of epilepsy has to be formulated by at least 2 neurologists with specific competence in epilepsy. And that means not just training, but also board examination. The presence of epileptic automatism has to be documented, not just by history, but by video EEG recording, which we did in his case. The presence of aggression should be verified through video. Again, this was done. This is sometimes difficult to do just because patients may not have the video EEG monitoring. And the violent or aggressive action should be characteristic of a patient's habitual crisis. So very, similar for him. The clinical judgment has to be drafted by a neurologist certifying that the aggressive action is part of an epileptic seizure. And the other consideration is what we call the insanity defense, which encompasses the alteration of consciousness that can occur during a psychotic episode. Sometimes physicians are called to be expert witnesses and help determine the level of danger associated with an offender who committed a crime under the influence of a temporal lobe epilepsy. Patients can clearly be treated and even cured with medications or surgical intervention, and that lowers the chance of recurrence, but is not, entirely certain. This is another patient of mine that was quite interesting. Small town in West Virginia. He was a math teacher. He was 62-year-old when he came to clinic to be evaluated, accompanied by his significant other they'd been together for 26 years, just never got married. So he self-referred. This was his second opinion. The wife, the significant other, really just worried he's gonna die. She said, I think one day he's just gonna die in front of me. He wants us to marry. I will not marry him because I don't want to marry somebody that I know is gonna die in the next day or 2 or 3. She was clearly distressed by his events. He was very upset that he can't go on. He planned to retire in 3 to 4 years. Had a very distinct daytime routine. He would go to school 4 or 5 o'clock. He would leave school, maybe do some shopping. By 6:37, he was always in the house. He said, I have not been outside of my house after 6:30 to 7 until morning for the entire life. We can never go to a movie. We can never have dinner. We can never go on vacation because I can't have myself in the public with these events. It's absolutely embarrassing. And this video cannot go out and cannot be discussed. I don't want the people in my town I have a reputation I have to maintain. I don't want people in my town to make fun. So he was quite determined. He was diagnosed with temporal lobe epilepsy at the age of 9, had MRI and EEG recordings that were not helpful. He was maintained on 240 milligrams of phenobarbital, which is a hefty dose. Developed osteoporosis, needed treatment for that, peripheral neuropathy. He was clearly unable to drive. The events would occur 3 to 5 times per night, and almost every night, all of them while awake, and all of them after 6 o'clock. He has preserved consciousness. I never, ever get confused. I can talk. I just can't stop my movements. The love of his life, it was this woman that came to see him. Like I said, this was a movement disorder. It's called paroxysmal non-kinesigenic dyskinesia, believed to be temporal lobe epilepsy, which is the reason the phenobarbital was employed lifelong, many years, very high dose, made him drowsy, however, continued to take it. He really doesn't have driving restrictions because of the movement disorder, but you can imagine how difficult it would be to maintain control of the car if one of these should occur. He suffered significant epilepsy side effect for something he really didn't have. He was quite upset when we told him these are not seizures because he had such change in his medical health because of the phenobarbital and osteopenia and fractures and different surgeries he had to undergo. But essentially, the diagnosis produced a dramatic life and lifestyle change for him within pretty much 24 hours. They decided to get married. They did get married. We had an attempt to publish him at the Cinderella story in one of the local journals. We ended up not doing it, but it was quite interesting. This responds well to carbamazepine and a little touch of alcohol, what he calls one finger. So sometimes 2 fingers, and they're these 2 fingers, not these 2 fingers. So just very little alcohol and carbamazepine seems to control most of the events. He still continued to be quite isolated at night, but now he lived in the same house with his wife. Before, they owned a duplex, which was really separated by walls, just because she did not feel like she can commit unless we knew he's not going to die. So I think medical-legal aspects of epilepsy are quite profound. There are many articles about this, but and you can imagine how somebody could be called as an expert. There could be clear involvement in criminal cases for alleged crimes or attempted crimes. And there are several other civil cases, involving child protection, personal injuries for sure, medical negligence in some way. So this can take many aspects. I think one thing I would say is when somebody reports episodes, try to see a video. It's important to see what the other person, to hear what the other person sees. It would be nice to have a video. Sometimes the face, the upper trunk, or sometimes the whole body, but the face is very important. We have patients complaining of, episodes or spells all the time. And I think our residents know one thing: if you can ask one question only of the person that has witnessed the event to see if those are real seizures or not, would be what?
Eyes open.
Are the eyes open or closed? Patients with real seizures will almost always have eyes open. Eyes closed usually indicates a non-epileptic event. It doesn't mean it's, done on purpose, but it's a non-epileptic event for the most part. Patients that do have seizures on purpose and have to be persuasive, usually they close their eyes. There is almost always left to right eye movement. Try to do that for about 2-3 minutes yourself. You're probably going to throw up. So eye closure removes the visual stimulus and makes the movement more continuous and consistent. Epilepsy is a positive phenomenon. So if somebody has a seizure and I'm right-handed, I'm going to have my seizure with the right hand because I do a better job. Or somebody has a negative phenomenon, a stroke, and that they fake the stroke or the deficit, they tend to have it on a non-dominant side. So eye opening or closure is important. The hand movement, it's important. So, and then if you can do 2 things on exam to determine if that was potentially a seizure or not, we do what?
Try to stop the movement.
No, on exam. What do you look for exam? Tongue biting?
Yeah, and urinary incontinence.
No. People can have urinary incontinence on purpose. People don't usually bite their tongue on purpose. And if they do, it's usually on the tip of the tongue. But when they have a seizure, they'll have their tongue biting laterally. And sometimes you look at a patient's tongue and you see that they look like lace, it's like carved, and those are patients that have real seizures. Upgoing toes. You can fake that. And usually you can have upgoing toes up to 24 hours. So it will probably take 15 seconds. Were the eyes open or closed? Stick your tongue out and check their toes. And you probably have a diagnosis in 15 seconds. So, all right. I think I might stop here and take questions. If anybody has any.
Lights on. We had about 70 participants online, so
Just 80, actually.
80. Okay. Do we have any questions in the room to start?
I guess one question, at what point, so I saw the one that was it looked almost completely like a psych thing, like the prisoner that came in.
Yeah.
And then it ended up being like a temporal seizure. Yeah. At what point do we start looking for neurological causes for some of these kind of people that were so quick to call antisocial or something else?
I think the psychiatric disorders are almost always an exclusion diagnosis. I think you have to do the proper workup to the extent that you feel is necessary before you rule everything out and you declare them psychiatric. And I think many times seeing is believing. If you can get a video from anybody in the family or a video that you record in the hospital, I think they'll be beneficial.
We have questions.
We don't want this yet.
I have one question for you. I was thinking about the concern for SUDEP, this unexplained death, and I wondered if there have been any interventions proposed for that. I'm thinking ICD implantation is not, necessarily appropriate. We're not going to try to shock asystole, but are there any outward, like that, or any sort of For people who maybe live alone, like, is there any intervention that they?
So the vagal stimulator has some data to show that they, they're beneficial for so they're trying to prevent, with the idea that the auto stimulation present on the device, which is triggered by the heart rate changes,
Okay.
and can be set off as a percentage, can make the device, come on and essentially, stimulate the brain to try to abort the seizure. The typical factory setting is 20%. For somebody who's asleep and they're 60 beats per minute, sometimes even waking up to go to the bathroom will make the heart rate jump to 72. So that triggers the device. It's inaccurate. The device cannot tell if it's a seizure or not, but it does work.
Okay.
We have the NeuroPace, the responsive neurostimulation device, for epilepsy, which means EEG Dept electrodes, which are long electrodes like needles that have electrodes around the 5 millimeters apart, about 6 of them. So those can be going straight in the brain, and could be placed on the surface of the brain, or sometimes kind of placed around the gyre, especially the temporal lobes, that record lifelong the EEG. And when a pattern of seizure is recognized, then we give that pattern to the device. It can trigger stimulation to stop the seizure. I have a patient of mine that so the device is approved now for partial epilepsy. We're part of a clinical trial that looks at primary generalized epilepsy, which are all convulsions, lifelong disease, big seizures. The goal was to enroll for patients, and the study ended. And they're looking for FDA approval probably by September. It's been very beneficial. So this patient was actually outside the study, but given the results initially, she agreed to have it on. So it was kind of off-label use, but very much needed because of fractures and everything. She was implanted in January, and then I saw her in March. We turned it on and saw her again at June, so 3 to 4 months interval. And Dad was there, and I said, "How do you think you're doing?" And she said, "I'm doing great. I haven't had a seizure." And I said, "Oh, that's good. I mean, you're having 3 to 4 in a month." She said, "Yeah." And I said, "Dad," I said, "Did you see anything?" He said, "Nothing." And I said, "Okay, so let's look at the device." So we download the data and we present the patient. This is what your brain has done. She had 28 seizures between March and June. She wasn't aware of any of them. So the device recorded all and treated all. So she was completely unaware, maintained the same medications, nothing was changed. Given the fact that she had the VNS on, I said, let me do like a head-to-head trial. This is perfect. I want to see what the auto-stim is coming on. So auto-stim comes on when it takes a heart rate change. It came 0 times on during that entire time. So it was just not as sensitive. It's possible that just because this one acted on soon, there was not enough heart rate change for the other ones. But head-to-head, this seems to be the device for Sudet, because it records everything and treats everything.
It's really great.
I think always the question is, what do you do with somebody like this that wants to drive? I mean, she had 28 seizures.
Right.
I can't prove that she did not have loss of awareness, but then I shouldn't punish her for having 20 seizures when she thinks she's done great. Like, the purpose is to let them go to school and get a job and drive. And many times driving is part of the job. So it's a difficult question. So, because not everybody has an RNS. So,
Very interesting.
yeah.
Thank you
I
so much.
have a question from online. It's from Dr. Marcus Stoddard. He's in the stroke team, and obviously one of our veteran cardiologists. He wants to know, are there any ablation procedures for seizures with a focal point?
Yes. So those range from plain temporal lobe to we do LIT, laser interstitial thermotherapy, where we try to kind of cure that focus with laser. There is also something called so there are migrational disorders that are clumped and many times cannot be entirely removed. So what we do is we cut almost like the core of the brain out, try to separate those clump of neurons from the remaining of the brain to stop the seizure. So it's not really a resection, but it's a disconnection. So we try those. They don't always work, but there are several ways to treat with focal epilepsy or resection.